Now we will move into our main session on today's featured topic presented by Dr. Rodriguez, Breakthrough Therapies for Parkinson's, the latest and the greatest. And Dr. Evidente will be joining Dr. Rodriguez following his presentation. Dr. Rodriguez, please proceed.
All right, very good. So Taylor, just a really quick question. I imagine that I will be able to share my screen. Am I right on that?
You are correct. So you are able to share your screen. Do you see that green button at the bottom?
Yes, I can see it. Just give me 1 second and we will make this happen. So I think I am sharing my screen right now and I should have my presentation. Just give me 1 second.
No, you're fine.
Let me see from the beginning. There you go. Here we are. Okay, well,
thank you.
Taylor, thank you for that introduction in first place, and in second place, thank you to all the patients and the caregivers that are joining us tonight. I really love having the opportunity of spending time with patients and their caregivers, and talking about Parkinson's disease and talking about everything that is new and everything that is expected to come very soon for the care of people with Parkinson's disease. And in third place, I am very excited to be able to share this forum with Dr. Evidente, a very well-known leader in movement disorders. You know, I have had the opportunity to share some conferences with Dr. Evidente, and it's a great pleasure to have this opportunity one more time. Tonight, I will be speaking about the history of the medicine for Parkinson's disease, and I will be paying attention into what we need, what we have now, and where is it that we are going. So let's go ahead and begin. And we're going to go back to before the 1900s. You know, back then, 1817 was the description of Parkinson's disease by Dr. James Parkinson. And back then, in the 1800s, there was not a formal treatment for people with Parkinson's. So one of the things that used to be done, not only for Parkinson's disease, but also other medical conditions, is something called venesection. And venesection is basically a procedure that is also known as bloodletting, which consisted of making small lesions in the skin. And the idea was that that would let whatever was bad inside the body to get out, right? So obviously this was complicated by infections. It was not helpful. It was not a formal treatment. However, that's all they had at that point. And years later, Dr. Charcot, who's one of the fathers of neurology, introduced the use of beta alkaloids, hyoscyamines, and also vibration therapy. And you know what, is still today we're talking about vibration therapy. However, these are medicines that they're coming from plants. So these are plant-based agents. They were prepared as pills, and then they were prepared also as a powder. And they used to put it on white bread or mix with syrup, and they will give this to people to help improve the symptoms of Parkinson's. Those medicines actually might have had some benefit. Now we know that there is some anticholinergic effect associated with them, but that was the initial treatment for Parkinson's. After that, there was more treatments and more options coming, and doctors in the United Kingdom, in England, were already talking about the negative effects of mental strain and physical exhaustion. And they were actually recommended that people with Parkinson's should live a life that should be quiet and regular, free, and as far as may be from care and work, which brings a concept very interesting, because I think that everybody with Parkinson's disease or caregivers already are aware that when people with Parkinson's disease are anxious or stressed out, the symptoms seems to magnify. It's like a magnifying glass for Parkinson's disease. For the treatment of tremors, he used hyoscyamine, and also noted that arsenic, morphia, which is a morphine compound, hemlock, and Indian hemp, which is cannabis, they seem to be effective agents for the temporary improvement of the tremors. And writing specifically of the power of cannabis and opium in combination, he stated that he has several times seen a very distinct improvement for a considerable time under their use. Now, what was the active ingredient there that was helping? We really do not know. However, we have to understand that every time we calm down and we take care of stress and we relax the person that is having an exacerbation of the tremors, we must see an improvement in the symptoms. It was not until the 1970s that levodopa was introduced. Up to that point, all the management of Parkinson's consisted mostly of supportive physical therapy, management of the drooling, management of the skin condition or the seborrhea, ulcers and infections that will be seen in people with Parkinson's disease. And other than this, there was nothing else that was offered other than a particular type of surgery that was called an ablation surgery. And that was introduced in the 1900s. And in this type of surgeries, what they will do is they will either lesion, they will heat up and burn a small part of the brain, causing some improvement of the symptoms, or they will remove a part of the cortex, which improved the tremor. However, there was weakness and other undesirable side effects because it was like causing a stroke in that patient. So it could have been very, very disabling for some of them. And in the 1940s, now doctors knew at that time that if they will target the basal ganglia, that was going to be a better option. And that was very, very, very important because if we go forward in time to this day, surgery in the basal ganglia is actually considered to be the main therapeutic option for some people with Parkinson's disease where the medicines are not helping. But we are going to talk about it. I will go into detail a little bit later. The first levodopa reports actually came out in 1961. And basically what happened at that time, you know, the way that it was described is that patients that were bedridden, unable to sit up, they could not stand up, they needed help, they could not walk on their own, were able to do all those activities after L-dopa, levodopa. And initially it was only levodopa. It was not carbidopa, levodopa. And in the description, the doctor said they walk around with normal associated movements and they could even run and jump. Those that didn't have a voice, the voiceless, a phonic speech, and those with unclear articulation became forceful and clear as a normal person. So it was very interesting because I was not born back then, but I had an opportunity to speak with some of the doctors that were actually working on this work. And they thought that they had a cure for Parkinson. They said, you know what, this is the cure of Parkinson's. We need to move on to new disease states because this is it. Like, we don't need to do anything else for Parkinson's disease. And based on that description, let me show you. This is a patient with Parkinson's disease that has never seen treatment. This is a video of one of those first patients that was part of the clinical studies. You see that he's trying to stand up. He is stuck there. So this is what they were talking like. These people are not able to stand up. They need help to being able to get out of a chair. You see how difficult it is for them to adopt posture, you know, and once again, this is a person that has never been introduced to levodopa. Look at them when they're walking. They have that stoop posture that is characteristic of people with Parkinson's disease. And a lot of difficulty walking, the flex knees. People might fall forward, and this happens to some people. They feel like the upper body is moving forward and the legs are trying to catch up. And then the patient had the tremor and they had slowness. So, you know, they're supposed to be doing this and moving their hand, and all you can see is that tremor and that major difficulty with movement in his hands. And now we're proceeding to see the patient while the patient is not on levodopa. So now the patient is trying to open and close his hands, like making a fist and close, and you see how difficult it is. So this is what will happen if a person is never treated with levodopa. Very disabling. And even, you know, back in the day, the life expectancy of people with Parkinson's disease was 7, 8, or 9 years because there were no other good medications that could help the patient exercise and do the other activities that we wanted them to do. So I'm going to show you now this person after the medications, and then we're moving on into the meat of the talk, which we're going to be talking about this new treatment. So this is now the same patient, the same person after levodopa. Let's go ahead and take a look at him. Look at how easy it is for the patient to stand up. And while things are not perfect, he's able to walk a lot better. The symptoms are a lot more improved. So, definitely if you were the doctor at that point, you probably would have thought that that really might have been the cure and the end of the medical treatment of Parkinson, because there was great treatment. However, we know that over time, we learned that there were some complications associated with Parkinson. So levodopa, which is the main medication, the cornerstone treatment for the treatment of Parkinson's, was initially isolated in 1913, okay, from the fava beans, right? And I always try to remind patients that levodopa is a naturally occurring amino acid. By 1921, they were making levodopa in the lab, and they recognized by 1960s that people with Parkinson's disease had a dopamine deficiency in multiple brain regions. Intravenous levodopa was initially tried in 1961. By 1967, reports were coming out about the benefit of levodopa. And by 1969, they introduced the carbidopa. And that was the time that they had the combination of carbidopa, levodopa, and introducing carbidopa allowed for lower doses of levodopa to be effective and also for people to tolerate. And let me tell you that when they combined carbidopa with the levodopa, that's when the medicine was called Sinemet. And Sinemet means, sin means without emesis, which is vomiting, so without the vomiting. So that's where the word Sinemet comes from, if you never knew that fact. In 1975, the combination of oral carbidopa, levodopa was approved. And then after that, we knew that we had a great drug to treat Parkinson's disease. However, over time, the main challenge has been, can we deliver this medication better in such a manner that patients will be able to have a consistent benefit and minimize the side effects of the medication? And that's where we are moving now. So what are the needs that we see in Parkinson's disease? So in first place, we want to cure Parkinson's. That is everybody's aim. Everybody's looking for the cure. And you know what? I hope to see the day that we find a cure for Parkinson's. I don't mind having to find another job. We'll move on to take care of another medical condition. But before we find a cure, we will settle for disease modification. And what we're talking about here is, can we slow down the progression of Parkinson's disease? We also need treatment for what we call the non-motor symptoms. And we're talking about apathy, fatigue, hallucinations, depression, mental fogginess, insomnia. And we need better treatment for the motor symptoms. So we have levodopa, it's very useful, but still the problem is that some people take it, sometimes it works well, sometimes it doesn't work well. Sometimes it lasts for 4 hours, sometimes it will last only for 2.5 hours. So that's what we're trying to fix. And also we want to minimize the dyskinesias, we want to minimize dystonia, and we need better treatments, at least in the meantime. So when the medication is not helping well, the patients can take it and find some benefit. So let's talk about recent therapies that have been approved for motor symptoms in Parkinson's disease. And it's 2022, but I'm going back actually to 2016, 2017, because it might be possible that some of you in the audience, even though you have been able to speak with your doctor, you probably are not aware that these medications exist. So the first medication I want to talk about is a medication called Kimobi. And Kimobi is sublingual apomorphine. And the first thing I want to clarify here is apomorphine has nothing to do with morphine. It's not a narcotic. Actually, apo means away from morphine. And this is an on-demand type of medicine. And this sublingual apomorphine dose, when the patient utilizes the medication, can take you from the off state, when the patient is having the typical symptoms of slowness, stiffness, rigidity, and tremor associated with Parkinson's, they can move on into the on state, and that could happen over a period of about 10 minutes. What I like from Kimobi is that it is quite discreet. You know, it comes as a small package. You just open it. You have a small strip that you will put under your tongue. It always reminds me to the uh, water to the dental strip from Listerine to give you good breath and give you a take care of breath issues. And it takes about 10 minutes. They will dissolve under the tongue and the patient will have some benefit. Now, this is a medicine that requires a titration. It's not a medicine that, at least I wouldn't recommend to give you a prescription, you take it home and you start on your own. Because while you get used to the medicine, some people might experience a drop in the blood pressure. They might have some nausea and some vomiting. So my recommendation is to do this under the supervision of your doctor or the nurse or somebody that knows about healthcare, so they will be able to monitor the situation. However, this is a great option to provide a therapy boost for those that are suffering from unpredictable off episodes. And by this, I mean those patients that feel that the benefit of the medication goes away before they are expecting it. There are multiple dosages of the medicine. The side effects are nausea. There might be a little bit of discomfort in the mouth because of the strip that we put under the tongue, some dizziness. Some people might feel a little bit sleepy. So once again, this is not for everybody, but if your doctor is recommending this to you, the truth is you will not be able to tell, and I as a doctor will not be able to tell whether you are a good candidate for that unless we try the medicine. So we don't have a way to predict. We have a little bit of an idea, but we don't have a way to predict exactly if you are going to be the best candidate. So you try it. If it works, wonderful. We continue with the medicine. If you are the one having the side effects and you cannot get over them, unfortunately, we need to move into something else, okay? So the indication of this medicine is for the treatment of acute intermittent treatment of off episodes in people with Parkinson's, and that is the main approval of this. This is a medicine that you're not going to be taking scheduled every day. You take it when you feel like you are in the off state and you need to turn to the on state. So this is how it looks, right? It comes in that wrapper, and in blue we have the small strip that people will put under the tongue. The next treatment that I'm going to be talking about is called Imbrija, and Imbrija is inhaled levodopa. And very similar to Kimobi, this is a medicine that is used for patients that are wearing off or they are losing the benefit of their regular medications they take for the Parkinson disease. And this is actually a brand new technology that provides levodopa in a formulation that can be inhaled. Long story short is that some people with Parkinson's disease have an issue absorbing the medications in the gastric system properly. So this is a therapy that bypasses the gastric system, seems to be more predictable, and people might start observing a benefit within 10 to 15 minutes and will last for about an hour, as we saw in the clinical studies. For some people, it might be a little bit longer, but typically in the clinical studies, we were looking for about an hour, because remember that this is intended to be a rescue type of therapy, on-demand type of therapy. So some patients might find the inhalation of the medicine a difficult step. So once again, this is something that you as a patient will have to try to see if you will be able to tolerate, because this can be a great rescue type therapy that bypasses the GI tract, which is predictable and well tolerated. And this is what many patients tell me. They tell me, doctor, sometimes I take my carbidopa, levodopa tablet. It takes much longer for me to get the benefit, but when I use a medicine like Imbrija, I feel like it is a lot more predictable. So that is the main goal of this medicine. Remember that this is levodopa, so the side effects that we see are very similar to carbidopa, levodopa, including nausea, vomiting, lightheadedness, appetite issues, lowering of the blood pressure, confusion, and dyskinesias. And the one thing that we need to add is that because it is inhaled, right? People that have serious asthma, bad asthma, or bad COPD, patients that were smoker, they have emphysema, then they might not be a good candidate for this. We don't have data, and I personally believe that it can make things worse. So I will recommend for people to stay away, but patients get a small inhaler type of device, and what they do is they will put a small capsule inside the device and they will inhale, right? So they will put it in, they will inhale, and they will get that levodopa in their lungs, and then they will let it go. and the dosage that you're getting is typically a good dose that has already been studied in multiple clinical studies to provide some benefit. The newest of the medicines that I'm going to present to you now is what I call the fractionated carbidopa levodopa. Let me tell you the rationale behind this medicine, because initially when you look at it, you might think, I don't think there's any use. I don't think this is much different from what we have already. But let me tell you what difference there is, okay? So from the beginning, we always had two main versions of carbidopa levodopa immediate release. Carbidopa levodopa 25-100 or carbidopa levodopa 25-50. This is like going to the store and there being a small size of a shirt and an extra large size, so nothing in between. So we didn't have flexibility for me to try to adjust the dosage of carbidopa levodopa to my particular patient. So this is a very wide range, so it doesn't let me tailor the dose of the medicine. I always try to compare this with coffee, right? So you know, coffee, some people like a lot of sugar, some people like little sugar, some people like no sugar. And this is the same thing. Like everybody's a little bit different, and they need different dosages. So some people can cut the tablet in half of carbidopa levodopa, but they cannot do that. You know, you cannot cut it in four to have more flexibility. So this is a therapeutic option that was designed by a neurologist that took care of people with Parkinson's disease. And the brand name of this fractionated carbidopa levodopa is Divi. And I want to show you how Divi looks, right? So Divi is a 25-100 immediate release tablet of carbidopa levodopa that is scored in 4 fractionated segments. Each of them has 25 milligrams of levodopa, so it allows you to cut it in. The problem with the other levodopa is that you can cut it in half, but then when you try to cut it in 4, then it spreads apart. You don't know if you're getting the right dose of the medication, right? So doing it like this, the doctors came up with this idea of, let's create a pill that can be cut in 4 different pieces to make it easier for people with Parkinson's to take and try to tailor, try to customize the dose of the carbidopa levodopa. So, you know, it took 50 years for us to have something like this. And what happened is, well, I wasn't sure, you know, we were looking at this from a different perspective. I'm pleased to see, and I already started introducing this into my patient population, and I already see some people coming back saying, doctor, it's actually a lot easier to manage this. So, you know, it has been quite rewarding to be able to introduce this. Another therapy for Parkinson's, and now this is a therapy that is to be used along with carbidopa levodopa. It's called Norians, and Norians, the generic name is istradefylline. And this is a class of medication that is completely different from everything we were working before, which is an adenosine A2A antagonist. And it is the only medicine in this class. And what happened is that there are 2 brain pathways that are affecting Parkinson's disease. And these medicines enhances movement by modulation of the indirect pathway, which is the pathway that brings slowness in people with Parkinson's disease. However, because it is modifying that slow movement pathway, some people might have dyskinesia because they will feel the effect of the carbidopa levodopa more. And just like almost every other medication for Parkinson, the possible side effects are dizziness, constipation, nausea, hallucinations, insomnia. We can see this in the patient population. Obviously, it's not that everybody's going to have these side effects, but people need to be aware, because in case that they happen and they are new after they begin the medicine, they will be able to relay that information back to the doctors. It comes in 2 dosages. So the one thing I like of this medicine is that it is once a day. You take your carbidopa levodopa as usual, and you add on this istradefylline once per day, and you begin with 20 milligrams a day for 1 week, and after that you go to 40 milligrams. Always watch out for dyskinesias, trouble sleeping, hallucinations, and dizziness. And once again, this is not a medication that you will take without the levodopa. You are not going to do that. You need to take this with levodopa. That is how you're going to have the most benefit. The next medicine I'm going to talk about is called Gocovri. And Gocovri is an extended release amantadine. And it comes in 2 different dosages. And the goal of this treatment is to decrease the dyskinesias, and the dyskinesias are those extra movements that you might see in some people with Parkinson's disease. In some cases, the dyskinesias might be mild in nature and they will not bother the patient, but some people will have really bad dyskinesias. So those will be the patients that probably, that will benefit the most out of this medicine. Potential side effects include dizziness, hallucinations, paranoia, nausea. Some people can have, just like a rash, it's a leg discoloration, dry mouth. Some people might have hallucinations. So once again, it doesn't mean that we should not try the medicine. What it means is that we need to know what are the potential side effects of the medicine. And the main indication is, number one, for the treatment of dyskinesias associated with Parkinson's disease. And very interestingly, after we started using the medicine, we started noticing that the off episodes were getting better in people that were taking this medicine. So eventually, the Food and Drug Administration, the FDA, awarded the indication that besides being a good medicine for dyskinesia, it can also help decrease off episodes. So it has a dual therapeutic option for people with a little bit more advanced Parkinson's disease, which are the typical people having some dyskinesias and off episodes. The other medicine is Osmolex ER, and Osmolex ER is another extended release formulation of carbidopa, of amantadine, right? Now, when we talk about Gocovri is a different pill because it is a pill that you take at bedtime, and they performed these very rigorous studies that demonstrated the benefit of the medication decreasing dyskinesias in people with Parkinson's disease. When we talk about Osmolex, Osmolex is more an extended release formulation. However, we don't have the same type of data that we have as with Gocovri. This is a medicine that you take during the day. So you take it in the morning versus Gocovri, which is a medical technology that you take it at night, the medication falls in your stomach, and slowly, when you're approaching the morning hours, it begins to release. So when you wake up, it is already in the therapeutic range. So that is why the Gocovri has an indication for dyskinesias and off episodes, while Osmolex has an indication for the treatment of Parkinson's disease and treatment of drug-induced extrapyramidal reactions. Because remember that a little bit earlier, I mentioned you that we have good medicines for Parkinson's. The issue is, can we deliver this better? And I always make the comparison once again, let's think about a telephone 20 years ago and let's think about a telephone today, right? Completely different story. Today I can book a flight, I can check my email, I can watch a movie, I can record another movie. 20 years ago, I have to stand right next to the wall with that cable and just put it in my ear. And the only thing I could do was having a conversation. So the question is, can we optimize? Can we make this more efficient? Can we make this better? The next therapy I'm talking about is called Ongentys. And the main ingredient in Ongentys is opicapone, and it comes in two dosages, 25 milligrams and 50 milligrams. Most people with Parkinson's will begin taking 50 milligrams and they will take it at bedtime. Side effects of the medications are dyskinesia, constipation, low blood pressures, dizziness, and weight loss. And let me tell you what is the main goal of this medicine, Ongentys. So Ongentys is a medicine, or opicapone, that some people with Parkinson's experience that they will take their medicines, they get the benefit, and then they begin to wear off. Then they take the next dose of the medicine, they feel better, and then they start losing the benefit. And then they take the next dose, they start feeling better, and then they lose the benefit, right? For some people, that process might be mild and insignificant, but for other people, that means that they will have an exacerbation of the tremors, they will have more difficulty walking, they can have freezing of gait. Some people might have anxiety attack or panic attacks even, right? So Ongentys or opicapone allows for you to have more benefit from the medicine, right? And long story short is there are multiple enzymes that live in your body that are trying to metabolize levodopa. What this medication will do is put a stop on those enzymes, allowing you to get more bang for your buck. The same dose of the carbidopa that you're taking, you're able to use more of that levodopa, so you get more benefit from the medicine. Once again, this is a medicine that is taken once per day, typically taken at bedtime on an empty stomach. Quite useful. And I'll have to tell you that sometimes I have had to lower the dose of the carbidopa, levodopa in some people because they actually get a little bit too much, right? So it allows me to actually down titrate, which you hardly ever see that when you're managing Parkinson's disease. So that is a potential option. So the most important thing and the message here is, while you are trying the medicine, you need to have good communication with your doctor to make sure that any adjustments that need to be done, that might need to be done, are done. So it exaggerates some of the levodopa related side effects, especially dyskinesia. Some people can have confusion and hallucinations. So you need to be in close touch with your doctor. Another medicine is safinamide. Safinamide goes by the name of Sadago, and this is a class of medicine that is taken once per day again. It's a monoamine oxidase inhibitor taken between 50 and 100 milligrams per day, once per day. And it is a therapy that has to be used to optimize. It optimizes the carbidopa, levodopa, right? So this is not a medicine. You just don't take Sadago or safinamide once a day without carbidopa, levodopa. You're not going to see a difference if you do that. This is a medication that is intended to be used along with carbidopa, levodopa, once again, to try to optimize, help the benefit that you're getting from carbidopa, levodopa. So, those are the main medicines that we have already approved, available, that you might be able to go talk to your doctor and they will be able to offer you this. Now I'm moving into some of the advances on deep brain stimulation. And I know that this is not new, right? We have been hearing about deep brain stimulation since the year 2000. And while this is not new, the therapies and the technology that we have today is much newer. So I have here a comparison of, a person using one of those old clunky cell phones. You see that there are only numbers for you to punch there, versus today that we have these very fancy smartphones that you can do so many things on them, right? So let me tell you what has changed with deep brain stimulation. So now we have something that is called directional leads and adaptive leads, with the goal, with the promise to bring better results and decrease the possibility of side effects. These adaptive leads, the goal is to adjust the stimulation based on what the device is sensing in the brain. So just imagine that these devices are in your brain and they're monitoring what is happening in the brain, and they will adjust themselves based on what they are sensing. This is just mind-blowing, great therapies. And I think that the next few years is going to bring even better things. The directional leads, the goal is to adjust the stimulation based on the deep brain stimulation placement. And the main goal of this is to focus therapy in the mainly involved areas. So the significance of this is that if a person is having a side effects from the DBS, then using a directional lead, I might be able to target the therapy only in a particular area and avoid those areas that might be associated with the side effects. And by doing so, we increase the risk, or we increase the possibility of having more benefit while decreasing the risk of having any side effects. So this is basically how this looks. So what I want you to see here is in the lead to the right, I want you to go to the first electrode, the letter A, on the left side. And you see that in the typical electrode, the typical lead, we turn the stimulation on, and it is kind of a sphere right in that area, okay? However, now let's move all the way into C, which is the newer technology, right? And with the newer technology, what we did was we changed that sphere into a different shape that will allow us to just stimulate the part of the brain that we want to stimulate that is involved in those circuits associated with Parkinson's disease, while we turn off the leads on the other side to try to not stimulate other parts of the brain that have nothing to do with what we want to do, which is improving the symptoms of Parkinson's. Let's talk about other unmet needs, right? And one of the things that we spoke about was Nuplazid. And once again, I know that Nuplazid, you probably have heard about Nuplazid for quite some time, but I participate on a multiple forums for people with Parkinson's disease. And still to this day, still yesterday, somebody mentioned Nuplazid, and many other people had no idea that this medication existed. And they had family members having hallucinations that were not being treated. So Nuplazid, the active ingredient is pimavanserin, and this is the only medication approved by the FDA to treat hallucinations and delusions in people with Parkinson's. It is taken once daily. And the important thing of Nuplazid is that it does not block dopamine. So in Parkinson's disease, the dopamine levels are low, and the medicines to block hallucinations are dopamine blockers. So that's why they can worsen the symptoms of Parkinson's. So Nuplazid or pimavanserin uses a completely different mechanism of action with the main goal of blocking these hallucinations without worsening the symptoms of Parkinson's disease. So other medicines available, they treat hallucinations by blocking dopamine, and by doing so, they can worsen the symptoms of Parkinson's. The one thing that I want you to be aware of is that there is a black box warning that you must be aware of. And the black box warning is basically that there is in a particular segment of the population a risk of sudden cardiac death. And these are people with dementia and hallucinations related to the dementia. It is not exactly what happens in most people with Parkinson's disease, so it's completely different, but nonetheless, it is something that I want to make sure that you are aware of. But I'm going to tell you something. For most of my patients, and even if they were my family members, these medications are useful and they can be used. All we need to do is have close monitoring with your doctor. This is a medicine that is typically well tolerated. In the clinical studies, it showed that it can decrease hallucinations and delusion. Now, the one thing is that in severe cases, it might take a little bit longer than what I expect. So a reasonable time frame for you to try this medicine is about 6 weeks. So be careful about that. Don't wait until things are really bad to make the decision about taking this medicine. There is a symptom of Parkinson's that I'm just going to bring to your attention. Once again, this is not a new medicine, but I just feel it is important. There is a symptom of Parkinson's called orthostatic hypotension, which is a sudden drop in blood pressure when you stand up from the seated or lying down position, and people may feel dizzy and they faint. They feel like they are going to pass out, and some of them will pass out. And this is a very challenging condition, typically associated with more advanced Parkinson's. And many patients feel this cloud covering the brain, like there's a cloud hovering in their head, and they feel fatigued, they're falling, they feel tired all the time, right? So historically, we have used two medicines called fludrocortisone and midodrine. However, now there is a medicine called droxidopa that is used for this condition. And while it's not that new, it is unknown to many people, and you should be aware of it because it might help you or it might help your loved one. And this has been around for quite some time. And I bet that some of you are saying, my family member has that problem and I didn't know about that medicine, because it always happens, right? This medicine has been around now for quite some time. I'll tell you, it's even available as a generic already. So I want you to be aware of it, because remember that you have to be your own advocate to some extent, right? Some doctors will be able to spend the time about this with you. Some doctors, unfortunately, they are in a different setting. They might not be able to spend all the time to explain this to you, right? So I just want you to be aware of this. So droxidopa helps improve the orthostatic hypotension. It's a medication that helps increase the blood pressure safely in patients. And the one thing that is very interesting, right, is that at one point in the United States, this medicine was being investigated for the treatment of freezing of gait, and that was in April 2012. However, the study was eventually withdrawn. And let me tell you that the study was withdrawn because not many people wanted to participate in the clinical study. So I'm just going to make a quick pause, right? This is where Dr. Rodriguez speech for 30 seconds, which is there are many clinical studies and there are many promising medicines that we're testing, we're trying to bring to help people with Parkinson's disease, right? But the system in the US and the system around the world requires for carefully performed clinical studies. So we're doing those studies. People that see patients with Parkinson's disease, just like Dr. Evidente, myself, many other doctors. There are many doctors like us that we want to help people with Parkinson's. We work and we collaborate with the sponsors to bring these studies to you. So always when your doctor offers you or talks to you about a clinical study, always listen about it, because I truly believe that this medicine could have been quite promising based on my experience, but unfortunately, we do not have an approval for the treatment of freezing of gait. Now, what is in the pipeline, right? And we're gonna start wrapping this up now. There are multiple medications that are being under investigation to modify. And when we talk about modify, is slow down the progression of Parkinson's disease. The GLP-1 agonist, which is the first bullet point there, interestingly, those are medicines, a lot of them used for the treatment of diabetes that we believe might help slow down. And a lot of these medicines are already approved for diabetes. So we have plenty of data about them. However, it has been difficult to get people to come and participate in the clinical studies, those that are considered the candidates that we need so we can demonstrate the benefit. But many people are, have taken a little bit longer to find the candidate for this, because while we see them many times, they're afraid, and which I completely understand, right? But we appreciate those that participate in clinical studies, because they will move us closer to that day where we're going to find a cure for Parkinson's. There are some immunotherapy drugs. The main one I'm going to mention is prasinezumab, which right now is under clinical trials. And this is a medication that we feel might help slow down Parkinson's. There is a drug called nilotinib, which is a chemotherapy agent. However, they are still looking into this because the team that was working on it, they feel like there might be something there that really can help people with Parkinson's. So that is not off the charts yet. There is multiple compounds, including gDNA, that has been in the race to see if they can slow down Parkinson's. And then there are some other medicines, EMT01, mannitol, memantine. We suspect that they may help prevent the formation of alpha-synuclein. In the pipeline, interesting medicines, now that I was talking about this EMT01, is this EMT01 is a medication that has been studied for the treatment of Parkinson's disease-related constipation. And the company that owns this medicine already completed a study about the treatment of constipation in people with Parkinson's disease. And the study seems to be positive, promising for now. It is moving forward to continue research. The other thing is that the same drug is being tested now for the treatment of Parkinson's disease, dementia, or cognitive issues associated with Parkinson's disease. And there are some other drugs that are now being tested for the cognitive impairment or the memory issues that might be associated with Parkinson's disease, problems with cognition, memory, and attention. So once again, there are multiple compounds. Talk to your doctor. They are going to guide you whether this might be, you might be a good candidate for this. These are not approved medicines. So this part, when I'm talking about the pipeline, these are medicines that are now under testing because we believe that they might play an important role in Parkinson's. Talking about symptomatic therapies, there are multiple gene therapy studies aiming to deliver genes to the basal ganglia that will make dopamine. There are stem cell studies moving on. There's a study by a company called Blue Rock Therapeutics, and In my clinic, actually in Central Florida, we're going to start a study very soon on stem cells as well. The first study in the United States. There is a multiple studies going on about the use of subcutaneous levodopa infusions, and this is important because I talked to you earlier that some people with Parkinson's disease have issues with absorbing the medicine, problems with the GI tract, where they might not get the medicine. So now we're delivering this medication under the skin subcutaneously using a very small device that will deliver the medications 24 hours a day, trying to imitate what the brain should be doing. And then there are more advanced DBS, more advanced brain mapping technologies. So doctors will be able to put these devices even more accurate to increase the chances of a patient being successful. This is how the subcutaneous levodopa device looks like, right? The person will put a small patch that will deliver the medication to the skin, and then this is a very simple photo where the patient is carrying as a necklace, and what they're receiving there is carbidopa levodopa. There are some other medicines in the pipeline. If you look at this here, there are more than 70 compounds that in any shape or form are currently under investigation, trying to find out how they might be able to improve the life of people with Parkinson's disease in multiple areas, not only movement, but also apathy, depression, hallucinations, trying to make memory better. So be aware of this, because these are exciting days when we talk about this, and we need patients. We need people to eventually participate in the studies in order for us to be able to answer that question. I mentioned you the ENT01 study. So look how this study looks in particular. And this is a study that was looking initially into constipation, and we have some data released by the company, made public, that tell us about the benefit in constipation. But now they're going to evaluate the role of this medicine in Parkinson's disease psychosis and Parkinson's disease dementia. And these studies will be starting very, very, very soon. And with this, I'm just going to make a quick stop here, because